Thank you very much for the invitation and for that introduction, and I have nothing to do with football. So just really honored to join some of my colleagues, and many of them I respect very highly, Dr. Sledge and Dr. Guerra. Dr. Handel is over there in the corner, and then I think Dr. Wingfield is gone. Oh, there you are. Sorry. The lights are blinding me. So it's good to see you all. And so I was asked to speak about a population that Dr. Sledge just led us right into, and that is rural populations. I'll tell you the drive over from Columbus this morning, I passed through a lot of rural areas. My husband was nice enough to come with me, and he's like, "It's pretty flat here." And I said, yeah, these are my people. Okay, so just some disclosures here that I do not think will be relevant to what I'm going to talk about, but we are going to talk about rural populations in the U.S., and the green area on this map indicates non-metropolitan, which is the technical term you're to use for rural populations, just so a visual representation for you all. So 72% of the U.S. land mass is classified as rural, and 19% of the population of the U.S., or 46.2 million people, reside in rural America. And rural is not rural. So, we have rural areas like I drove through today. We have farmlands, we have mountains, and we also have frontier. And yes, even in 2025, we still have frontier in the U.S. And the populations that reside in those areas are really very diverse and include Black, Hispanic, American Indian, Alaska Native, Appalachian, and white persons. So it really is extremely diverse. Rural populations possess character and culture. They are a great source of food for us and raw materials as well as energy. We get our drinking water a lot of times from rural areas, and they also are known to have cleaner air than the cities. And many of us will go to these areas for recreation. Some other characteristics of rural America, however, it is noted to have lower income and higher rates of poverty among the residents. Is actually less populated than the metro areas, and the population is declining in rural areas. Residents of rural areas have fewer or less access to healthcare resources. So I work a lot in Appalachia, Ohio, and there are 7 counties that have no mammogram facilities. There are about 5 counties that have no hospitals. Transportation, I've talked to a rural primary care physician, and he said, we don't have Ruber here, rural Uber. And public transportation is virtually non-existent. So if transportation is a problem in the urban areas to get to medical appointments, this is the number one barrier, as we've talked about. It's even worse in rural counties. Residents tend to be lower educated and rely on public health insurance. There is an older population, and they travel great distances, and they're used to traveling great distances to get food, to get health care, and many of them are isolated. In addition, in 2025, there still is a digital divide in terms of internet access. I can go to Quaker City, Ohio. The minute I exit the highway, I have no cell service the entire time I'm there. And it's 2025. In addition, we have significant risk factor differences in these areas. Higher tobacco use, obesity, and lack of physical activity. Lower screening rates for breast, colorectal, cervical, and lung cancer. Incidence rates are lower compared to metropolitan counties, but mortality rates are higher. So what does that tell you? Less access to screening, more advanced disease. less treatment. And specifically, we see higher mortality for lung, laryngeal, colorectal, and cervical cancers, and these are mostly preventable cancers. This was now some information and backs up what Dr. Sledge was talking about in terms of healthcare access. So the supply of health workforce for primary care providers. Urban location is about 53 per 100,000. Rural location, about 40 per 100,000. In addition, high physician turnover. Specialists in urban locations is 263 per 100,000 versus rural 30 per 100,000. Oncologists, again, backing up what Dr. Sledge said, 7% practice in rural locations. Remember I said 19% of the population live in rural locations? Okay, 7%. For radiation oncologists, 24.7% of people who reside in a rural area have access to a radiation oncologist versus 98% in urban areas. And travel time to an NCI-designated cancer center, it's 180 versus 57 minutes. 180 minutes for somebody in a rural area versus 57 minutes urban. To an academic-based center, 105 versus 22, and any specialized care center, 59 versus 11. So you can see the greater burden put on rural residents just to obtain health care. In addition, when I first started working in Appalachia, I got a grant to look at cervical cancer, which is one of the cancers that I showed you was elevated. And we went in the community and started talking, and oh, no, we don't talk about cancer. We don't talk about cancer. And we certainly aren't going to talk about cervical cancer because our girls don't have sex. So how are you going to do a study where you can't talk about cancer and you can't talk about cervix? So how do you reach rural populations in the U.S., especially regarding cancer care and cancer? So first of all, you need to reach the population. So define who? Define the population and find the gatekeepers. We found the gatekeepers, and I always work with gatekeepers when I go into the rural areas because I grew up in New York City. I'm a Queens girl, and I'm not going to be as accepted in these communities. So I find the gatekeepers. And then you understand, you respect, and you value individuality. You listen and you guide. We're introduced by key community members. I'll show you a map in just a half a second here of all of our community-based cancer coalitions. And we also use key informants and the community itself. We go out in the community and we form community advisory boards. We establish trust. We're visible in the community. I send my staff there regularly, and we make a long-term investment. When the grant goes away, we don't leave. We don't helicopter in and out. We stay there. I've stayed there since 2003. Myself and my staff, we stay there. And we give back to the community and help them find solutions, and I'm going to give you some real examples of that. So here's the map. This is Appalachian, Ohio, right there at the cutout of Ohio, 32 counties, and those are where we have our coalitions and councils. And I will tell you, because of the work we've done, we got a call a few months ago from a community member in one of the counties, and he said, I want to form a new coalition across 10 counties in Ohio. Most of these coalitions are one county or so. Across 10 counties in Ohio focused on cancer. Would you help us? So yes, we are having our first meeting April 15th, and we're inviting everybody. And for all of these coalitions, we help them get 501c3 status. We help them with their organization and rules of engagement. We taught them Cancer 101. These are just some of our coalitions. We also produced a document. You can see this is in 2010, but we produced a document, first time, the cancer burden in Appalachia. And we published that and distributed it. So this is what I was talking about, where you give back to the community. So we follow this model. It's called the give-get model. It's in the literature. And these are just a few examples of what we do. So we had some community members come to us in Gallia County and say, we've got about 48 women who have abnormal cervical screening, and no physician in the county will see them because they don't have health insurance. This was before the Affordable Care Act. And I said, bring them to us. We'll take care of them. Thank you, Dr. Paskett. They don't have cervical cancer, but we want to establish capacity locally. I said, okay, what do you need? So we helped them write a grant, and they got a small grant to get a colposcope. And then they did bingo runs and poker runs, etc., to buy the biopsy forceps. And they set up this clinic in the health department. It's still running. And they run once a month, and they get a doctor to volunteer. But they've screened over 100 women with abnormalities, and 6 required further treatment. The giant colon, we take that all over. They love the giant colon to walk through, and we partner with local primary care providers to give fit tests after they come through the colon. We've had Komen grants where we bring the mobile van, and if women don't qualify for the Ohio Breast and Cervical Cancer Screening Program, which gives them free mammograms, then we had a Komen grant that would pay for that. And then one county, Benton County, did not have a grocery store for 4 years. No grocery store in the entire county for 4 years. People had to travel 35 miles over to Athens County to go to the Walmart. And so we with the community, got a small grant and helped establish a community garden, teaching people how to grow fruits and vegetables in containers, etc. Those are just some examples, but we've written over 50 grants, gotten the community over $500,000. None of it comes to us. It all goes to the community, and then they help us, when we need to do our big NIH-funded grants, and it's really, really a great model. And I can tell you, they call us, and we love to help them. So I wanted lastly just talk a little bit about a survey that we did. We were funded to do a supplement to increase community outreach and engagement in our cancer center. And one of the aims of the supplement was to conduct assessments with healthcare facilities in the 55 rural counties of Ohio. And so what we did was send out this survey. So I'm just going to show you the results focused on research. So the survey assessed clinics' interest in intervention and research areas in prevention and control. And colorectal cancer to them ranked the most important, closely followed by cervical and then breast. Then we asked them about electronic medical records. Do you have electronic medical records? And what are the main benefits from them? And most of them focused on clinical information, billing and coding, et cetera, not really implementing that to identifying patients for research was what they thought that was used. So according to our survey, 58% of the clinics had never been involved in research. 20% were currently involved in, about 14% have participated within the last year. And the type of research was health services research other than clinical trials, behavioral sociologic research to understand human behavior, and service-based research mainly to enhance a public health program like a QA or something like that. No clinical trials. No clinical trials out in the rural area. Why not? Not enough time, no financial resources, not staffed enough, not interested, not sure how to get involved. None of them said lack of support for management. But having done many studies in rural areas, I can tell you that is a problem also. So the barriers to clinical trial accrual is, first of all, most of our trials are from one location, the mothership, right? So that would be Cleveland, Columbus, or Cincinnati in Ohio, right? So that problem is travel. So we try to help people with travel. We have hotel vouchers if they need to stay the night. Locals versus, if we have the clinical trial accessible locally, do they have the capacity to do that versus competing demands? And to actually do some of our treatment trials locally, it's really, really hard for them to get certified to be able to do all that. Relevance, time constraints, cultural issues. I mentioned some of them. Social determinants of health. The patients who come in are more worried about transportation, food, rent, utilities getting turned off. That's a real problem in rural America. The cost, the equipment, and then again, the digital divide. Okay, can't necessarily do all of our nice, beam it up to the cloud in the clinic if we've got problems with internet access. And then the type of trials. Randomized trials tend to be a little harder versus implementation science trials, which is what we've done, where we go in and we teach the clinics, how do you talk to your patients in your 10-minute visit about colon cancer screening? How do you talk to them about HPV vaccine in 10 minutes? So we talk to them. So lastly, I want to just say, local solutions solve local problems. And for the overall picture, rural providers really want to provide the best care to their patients. They are wonderful. We've talked to them, and that's exactly what they tell us. Most providers also care about their community. They live in their community. Most of them have come from that community. But the practices don't have the capacity to do large, complicated research in terms of staffing, demand, resources, and understanding their electronic medical record. I could tell you tons of stories about that. The community is receptive to messages about improving health, depending on how messages are delivered and by whom. Somebody they trust, somebody who looks like them, talks like them. So to reach rural communities, we need to be invited, gain trust, use trusted community members. Meet them where they are, literally and figuratively. Individual barriers must be addressed, and the researchers must stay for the long haul and act with the benefit of the communities in mind. So thanks, and I'd be happy to answer questions at the panel.